So hello, everyone. I hope you can all hear and see us. I'd like to welcome you to today's event in our Diversity Matters webinar series, which is the first one in the new year that has just started. My name is Katharina Crepaz. I'm a senior researcher here at Eurac Research at the Institute for Minority Rights. And I have the pleasure of moderating today's webinar on the topic of health, diversity, and COVID-19. So, of course, this is a very timely topic as we approach what we all hope will be the peak and then also the start of the end of the Omicron wave here in Europe. And so hopefully we will be able to shed some light on the relationship between diversity and COVID-19, the pandemic that has been with us for almost 2 years now. At the beginning of the pandemic, we often heard these calls for solidarity in society. So that mentioned that everyone can be targeted by the virus, that there is no distinctions of race, class, or gender. However, right now, 1.5 years into the pandemic, we know that this is not quite the case. So that diverse groups have been particularly affected by COVID-19. And this is true for both the epidemiological and also the socio-economic impact that the pandemic has had. And therefore, to offer really a thorough and an exhaustive investigation of the reason for these developments, I think the cooperation of life scientists and social scientists is essential. And therefore, this interdisciplinary approach also is at the center of the webinar. First of all, please allow me to introduce today's speakers to you. We have two speakers, as mentioned already, from the social and the life sciences. So our first speaker is Rohini Mathur. She is an associate professor of epidemiology at the London School of Hygiene and Tropical Medicine. Her work focuses on the use of large real-world clinical databases to examine health inequalities. And she's currently completing a postdoctoral fellowship funded by the Wellcome Trust to examine ethnic inequalities in the care and outcomes of type 2 diabetes, and is a member of the Open Safely Collaborative working on a range of COVID-19 related projects. Rohini is also a lead for the London chapter of Health Data Research and is a deputy director of the London School of Hygiene and Tropical Medicine Center for Global Chronic Conditions. Our second speaker today is Okan. He is a professor of health literacy at the Department of Sport and Health Sciences at the Technical University of Munich in Germany. He has vast experience in research, practice, and policy on health literacy with focus on children, adolescents, and schools. And he is also the co-editor of several health literacy books, including the International Handbook of Health Literacy. And he's the coordinator of the Global COVID-19 Health Literacy Network and the International COVID-19 Project, as well as vice president of the International Health Literacy Association. So welcome to both our panelists today. And before we start, allow me to give you some final technical information. So we will have two opening questions and two opening statements from our respective panelists. And then we will, of course, have an open discussion with you as our audience. And you are very much invited and encouraged to also ask questions, and you can do so through the Q&A function. So without further ado, let's go to our first speaker, to Rohini Mathur. And as an opening question, I'd like to ask you to give us a short introduction to the relationship between different types of diversity and health.
Thank you, Katharina, and lovely to be here with you all. So this is quite a broad question, so I will try and be brief. So, yeah, as I'm sure you are all aware, there are many forms of diversity which can interact to influence our interactions with the healthcare system and our risks of health-related outcomes. And these include, but aren't limited to, a person's age or gender, whether or not they have a disability, their socio-economic status, or their ethnic background. But diversity can also relate to factors related to things about protected characteristics, such as your gender identity, your marital status, and also people living in vulnerable circumstances. So in the work that I do in large-scale electronic health records, I use ethnicity as a lens through which to examine health disparities. And this is partly pragmatic. We're very lucky in the UK that we are one of the few countries in Europe that emphasizes the need for positive action to promote ethnic equality via the collection of ethnicity data across all of our official government statistics and health services. And this is in contrast to some other countries in Europe and internationally where the collection of ethnicity data is illegal. And without these data, we are completely unable to explore disparities where they might exist. So I use the term ethnicity because that is the standard language that we use in the UK, and what we term ethnic minority groups, may not translate across different settings. So in the UK, the largest ethnic minority groups are the South Asian and African Caribbean groups, but this may not be transferable over countries and different contexts. So who counts as an ethnic minority is very subjective to time, place, and geography. So factors which influence diversity and health are mainly related to the social determinants of health, which are integral to our understanding of disease and mortality. And how these social determinants affect groups unequally is really the main question that we want to explore. And the concept of ethnicity is quite a useful tool to explore these differences because it can provide valuable information about shared exposures, both biological and social. So when we think about ethnic differences and ethnic inequalities, it's important to be clear about what we're actually saying. And we want to talk about the way that ethnicity, health outcomes are determined by factors related to ethnicity, but not necessarily by ethnicity itself. So as I mentioned before, these factors can include socioeconomic deprivation, but also things about your migration status, cultural practices, and lifestyle. And differences in these are what we generally term ethnic differences. And though we mainly want to talk about social differences, of course, there is pertinent genetic variation, which can influence health. And though the genetic component is often small, it can still tell us something very useful about predicting risk of developing conditions and outcomes. And this relates very closely to the work that I do on type 2 diabetes, as Katharina mentioned. And we can think about how these factors kind of accumulate across the life course to result in the ethnic disparities that we see in type 2 diabetes and many other similar conditions. So type 2 diabetes is a multifactorial disease driven by genetic, environmental, and lifestyle factors. And we know that in the UK, in similar settings, minority ethnic groups have an earlier onset of diabetes, on average a decade earlier, and at lower levels of conventional risk factors that we tend to see in white or European populations. So they are predisposed to develop diabetes early. However, then their early childhood and lifestyle experiences can influence, their predisposition of going on to develop complications and longer term outcomes. But also risk of diabetes are related to people's interactions and experiences with the healthcare system. So do people have access to timely and regular screening? Are clinicians aware that the profile of diabetes might differ between certain populations, and are they looking for risk factors in ethnic minority groups which may present differently from the majority populations? And there also may be differences in the effectiveness of treatments, accumulation of chronic conditions. So we can see that there are many different points along the life course where these different influences can interact and result in ethnic differences and outcomes. And that is not to say that ethnic minority groups are always at higher risk of poor outcomes. The direction between ethnicity and health is not unidirectional. For example, data from across England and Scotland show that minority ethnic groups have better overall health and lower all-cause mortality than white groups, which is one of the reasons why the excess burden of COVID-19, particularly in the early waves, was so concerning. There are also positive differences in health behaviors. So in England, census data show that while 90% of people who are Bangladeshi identify as smokers, the vast majority of them identify as non-drinkers. So there are positive aspects of people's religion, culture, and community, which can help with better health outcomes in some aspects. One thing that has been particularly pertinent thinking about ethnic differences in COVID-19 is relating to the way certain minority ethnic groups live in their communities. And there was some early work done looking at the role of living in multi-generational or large households on risks of COVID-19. And so there were lots of reports saying that people who live in large households are at risk of higher exposure to COVID-19, that they may have people who work outside the house or children who go to school. So while these things are also true risk factors for developing COVID-19, what these things didn't necessarily talk about is the advantages of living in highly connected networks and communities, and that these networks can actually facilitate engagement with health and community services and support overall mental health and well-being. So we need to think of the holistic aspects of the different ways in different communities live. And in terms of COVID, we've also seen important differences in outcomes for people with and without disabilities, living in care homes, living with conditions such as HIV and other long-term conditions. And these are all important aspects of diversity to consider. I think one key aspect of diversity, which is particularly related to ethnicity, is migration, and whether or not people identify as migrants and how that interacts with what their ethnic background is. So we know in the UK, we've seen poorer outcomes for people who are international migrants. And even though migrants to Europe may be young, healthy, and well-educated, the experience of migration itself can have negative influences on health. So there might be physical and psychosocial stress related to moving. People may not have the language skills or the social networks with which to find jobs and economic opportunities. And migrant groups may also experience stigma and prejudice. And all of these things sort of compound any kind of other existing inequalities. So I'll just finish up by saying that if we want to understand the relationship between ethnicity and health, we really need to step back and think about the bigger picture of how political and historical contexts shape all of the wider determinants of health, whether these be early childhood experiences, education, housing, employment, and of course, experiences of discrimination. And we need to consider all of these quite carefully when interpreting ethnic differences in health and understanding how to act on them in the best way possible. Thank you.
Yeah, thank you very much for this very interesting introduction into the topic. I think you've shown us quite well how interconnected the different factors here are, and how important it is to really see the big picture and look at all the potential variables that might have an influence on this very complex relationship between health and diversity. So another factor that is probably an important issue here and comes in the personal factors, I would say, or also in the structural ones, is the topic of health literacy, which I would now like to ask our second speaker to introduce us to. So could you tell us a bit about the concept of health literacy, and maybe explain also why catering to the needs of diverse populations is also very important in this regard?
Yes, of course. First of all, thanks, Katharina, for having me, and also thanks, Rohini, for this great input on diversity. And I totally agree with everything that you just said. So, and this is all important in context of COVID-19, but this is also so true when it comes to health literacy. And before we talk about the role of health literacy during the COVID-19 pandemic, of course, it is important to get a common understanding of what health literacy is, because I noticed in the past 5 to 7 to 8 years, and especially also here in Germany, but this is true for abroad settings as well, that everybody has a different understanding of what health literacy means. And of course, this is a symbiotic term. It contains health, right? Health, well-being, physical health, mental health, and literacy. And usually literacy, one translates with the ability to read and write. Then of course, this is a very backwards, a very traditional understanding of health literacy. But what one cannot do is, when combining the terms, just combining also the definitions that are behind the concepts of health and literacy. So this is not possible, and this is not doing just to the concept itself and what one can do with health literacy. And in a common understanding of health literacy, a common understanding that has been reached, as I said, again, there are many, many different understandings possible. But when I look on the areas where I do research, or the mainstream, the common understanding of health literacy is that health literacy is the ability to find, understand, appraise, and use health information, and to make decisions in relation to health that are based on having managed this kind of health information to promote health, in context of health promotion, in context of disease prevention, and also in context of healthcare. So we see health literacy, to say it with fewer words, is kind of a competence to manage health information. So, and that's totally different from when understanding literacy as the ability to read and write, or health in all its different dimensions. You can clearly see that when bringing these two concepts together, it becomes about something different, yet related, but different. And when we look on research in relation to health literacy, before the pandemic, there was a large European survey that has been conducted like 10 years ago in 8 European countries, a representative study. And the results showed that more than 50% of the populations in Europe had difficulties in managing health information. So they had low health literacy. And Germany was also part of the study. And the results, of course, were the same for Germany as well. So a big proportion of the German population had problems with health literacy. And in Germany, there were some follow-up studies based on that European survey, and they showed us that, in fact, in the past 10 years, the health literacy of populations was not increasing, but decreasing. So it got worse compared to the survey that we got 10 years ago. And just recently, the second European survey was conducted, this time in 19 countries, and it also showed rather similar results, also providing deep insights into digital health literacy, which is important, navigational health literacy, and other facets of health literacy, because there is not only the generic concept of health literacy, but there are many, many, many sub-dimensions, including mental health literacy, digital health literacy, cancer, diabetes literacy, etc., etc. So, and why is that? Why are the levels of health literacy decreasing and not increasing when the first study was conducted 10 years ago, the first European study? This is because we do a lot of research on measuring health literacy, on assessing health literacy, conceptual research, methodological research, but there are only very few interventions to address health literacy, or the interventions that are available that are labeled as health literacy do address something different than these information management competencies. So you see that there is a mismatch. And when we now look at the COVID pandemic, what is the role of health literacy in relation to the COVID pandemic? If you would have asked me before, what is the role of health literacy for promoting health, the answer, I could have given you the answer, but the answer would have been much more complicated, because health and health practices usually when it comes to self-management or disease care, disease prevention, are sometimes very complex. They're not so easy to explain. But when the pandemic started, it became obvious what health literacy is good for. Because with the pandemic, not only the disease came and challenged us, challenged whole societies, but the whole communication surrounding the pandemic, COVID-19, the coronavirus came. And with that came information en masse. So on all digital communication platforms, by using digital communication technologies, in an instant, everybody in the world, including media, citizens, on the internet, social media, in forums, in chat groups, via smartphones and tablets, etc., began talking about health literacy. So you could turn on the TV, you still can do, and then you will see somebody talking about health literacy, giving you information. So, and with health literacy, a person becomes capable of dealing with that kind of health information. So, and to put it into more practical terms, with health literacy, for example, people in the pandemic can access health knowledge regarding COVID-19, acquire new knowledge, right? And knowledge, for example, about the virus, the pandemic, or any other issue related to that. People also can use health literacy to understand the recommendations given by health authorities. For example, since day one of the pandemic, we receive a couple of behavioral recommendations that are important and people should adhere to in order to prevent getting an infection, including keeping distance, or washing hands, hygiene in general, doing testings, different kind of testings, including PCR testings, wearing a face mask, etc., etc., etc. So these information are being transported through health communication on various platforms, and health literacy helps to understand them and also the concepts behind these recommendations. Where do they come from? What are they for? How do they help me? How do they help others? And after a year into the pandemic, vaccination came. So people could also try to understand what a vaccination is, why it is important, etc. What kind of vaccines are there? Who are developing these? How can I get them? Where are the stations where I can receive vaccinations? What are the different target groups, etc., etc. You see, there are a lot of information, and through health literacy, people can access them. But it's not only about these functional areas, because with the health communication, when information comes, it is not a given thing that each information that you receive or each person you talk to gives you trustworthy information, correct information, reliable and valid information. With the pandemic comes often also disinformation and misinformation, fake news, false claims, conspiracy theories, and these kind of things. And they travel fast. Like the good information is traveling fast through the communication technology channels, the bad information, the inaccurate information is traveling as fast as the good information. And the thing is, information is traveling faster than the virus. So before the virus hit Europe, information on the virus hit Europe. And in this context, a term was coined, the infodemic, the information epidemic that came along with the COVID pandemic. The infodemic is not a new term. It was first introduced in 2003 during the first SARS-CoV outbreak of 2003. And it means that information is available very fast and travels very fast, and this information can be right or wrong. So, and having health literacy means that you can distinguish between good and bad information. You have the critical thinking abilities, the critical health literacy to understand what information is good or what information is bad, which one to follow and which one to avoid. So basically, health literacy helps to navigate the infodemic, because like the COVID pandemic, also the infodemic has come to stay. So there will be many states of emergencies, not even only focused or related to health, but it can be political, climate related, economically, cultural events that will have information coming with them. And that can also be an infodemic then, an overload of information. And health literacy is good for that as well. So, and having said all of these things, what health literacy is good for during the pandemic, we have conducted a lot of studies after the outbreak of the pandemic. A couple of international studies, as Katharina highlighted when she introduced my background. And I want to highlight two of these studies, one of which we have conducted in 5 waves in 3 countries, in the German-speaking countries, so a longitudinal study measuring corona virus specific health literacy, meaning health literacy in relation to specific COVID-related health information. And we found, for example, that's compared to generic levels of health literacy as measured in the European studies, our results were a bit better. So the levels of health literacy in the corona study were a bit higher than in the generic health literacy studies. And we understood this, we interpreted this mainly based for 2 reasons why the levels are better. First of which, since day 1 of the pandemic, there is a 24/7 communication about the pandemic on all media channels, and also in the private, in the personal networks, and the peers, the families, everybody's talking on it. It is impacting work, life, leisure time, everything. So people were faced with information on a constant basis. This has never been done before, that all the time this topic was impacting people, was there for people to access and engage with. That's the first thing. So that helped because people were engaging a lot with information. They could better handle information. And second, and this makes this pandemic so different to other health states or emergency states, the information that was communicated was compared to rather disease-specific information that is usually communicated much easier. It was just about keep your distance, wash your hand, wear a mask, and then came all the testing. Yeah, do the test before you go here or there, or only so many people are allowed to gather together. Crowds must be keep small. You can receive the vaccination here. These kind of vaccines are available. So very, very easy and easy to understand, and also easy to apply information. That made it easy for people not only to access the information, to find the information, but also to understand and use the information. So you see, that's a distinction. Similar results we found in another study on digital health literacy in students. And we did this study across the world in more than 40 countries with more than 100,000 students who completed the survey. And we found a rather similar results. The overall levels were rather high, and people could, the students could manage information on the pandemic very well. And this is the main difference between generic health literacy levels. But, and this is my last point, in both of these studies, we found that although the health literacy levels in these different groups were rather high, their ability to evaluate, to critically appraise information, so their critical health literacy levels, they were not so good. They had problems in evaluating information regarding different channels in their personal environment, in their near close social networks, or in relation to media information or online information. So although the levels of health literacy in relation to COVID are good, there is still a lot of room for improvement when it comes to appraising information, which in fact is important in context of the infodemic, of all the fake news, and the fact that now we can receive vaccinations, and it is very important for society and for the public health measures. And we need a lot of people to get vaccinated, and not only twice, but to receive the booster shot, and also in the future, because there will be variants, different variations of the virus, like we have it with the flu, with influenza, that there is a season, usually in autumn and winter, where you have to receive it. And as long as people are so critical against the authorities, the official sources, against the healthcare sector, it will be rather difficult. So there is need need for action on health literacy, and especially critical health literacy is something that must be important, that must be focused. So Katharina, I think I have answered the first question, but I have not answered to your second question, but I have talked a lot. So maybe I stop here and maybe I can come back to it later for the diverse groups.
Yeah, thank you very much. I think it's a very interesting topic here and a very I would say a critical issue also in general for our society. So how we can process information and how we can distinguish also correct information from something that might not be correct or that might be indeed spread exactly for the purpose of causing misinformation. Yeah. Yeah, I think we can go into the question of the relation to diverse groups in a minute, but I would like to come to Rohini again. Before we've now heard more about the side of us as a society, as the patients, as the consumers of information. So coming back to our role as scientists and gathering and presenting data. When you are gathering data on diverse groups, are there any difficulties that come up frequently? And what I was also wondering, as you've mentioned before, that the UK is one of the few countries that actually allows you to collect ethnicity or background related data in relation to health. I was wondering what can you do, or how difficult is it to reconcile trying to gather as much data as possible in order to have the best possible amount of information with maybe avoiding also then stigmatization of migrants, for example, as bearers of diseases, as it often happens. So how can you go about this challenge?
Thank you. It's a really great question. And I think there are several aspects related to the collection of high quality data on ethnicity and diversity, which are really important for researchers to think about. I think one of the biggest debates that we have is what categories should we use to define ethnic groups in the UK? And are these categories meaningful? Do they represent the populations that we're interested in? And do they relate to people's own self-identification? So I think one of the central tenets of ethnicity data collection in the UK is that it's people's own self-identified ethnicity. So ethnicity should never be assigned. It should be self-reported by people to reflect their own, feelings or identification, and with the understanding that a person's own self-identification may change over time. So, but as researchers, we need to operationalize this concept of ethnicity into pragmatic categories that we can use in analyses, that we can compare across data sets, and that we can compare across time. And so the ethnicity classifications that we use in the UK, in the census and in our healthcare data, they have been selected for pragmatic reasons, but they also reflect how people have been racialized, so how they've been influenced by historic and political forces. And I think some of the concerns that come up, in interviews and focus groups and conversations with the public is that the categories that we offer people may not be categories that they would ever use to identify themselves. People have a range of diverse backgrounds that aren't necessarily captured in the 16 categories that we have. We increasingly have people of mixed ethnicity, of ethnicities that don't even appear, in the standard classifications. And so there's also a concern that these categories may perpetuate racial stereotypes, that they may further they may other groups instead of saying that these are groups in which we want to identify differences. And so we're very cautious with our language and over-interpreting ethnic differences. So on one hand, it's really important for us to identify and describe ethnic disparities to help us tackle them. But on the other hand, we don't want to move so far as treating groups as homogenous or increasing stigma against different groups. And I think something that we found, particularly in the census, which we just had last year, is that we have increasing amounts of people who self-identify as the other ethnic category, which is this catch-all category for people who don't fit anywhere else. That really tells us that maybe it's time to reevaluate the categories, think of new ones, because people are increasingly not being represented properly. And this is a continuous problem. Every 10 years we update the categories because the population changes so much over time. So this is an ongoing issue with capturing data which is meaningful and interpretable for research. Another issue relates very strongly to what Orkan has just been talking about, is that whether people give or choose to share their data relates a lot to the trust they have in the healthcare system, how they feel people might use their healthcare data, and this is all related to their health literacy. So there's a lot of information on social media and in the news about how people's health data will be sold to third parties, maybe sold to pharma companies or insurance companies, and this may be used against people in some way. And so the onus is not just on patients and the public to have an understanding of how their health data are used, but for us as healthcare providers, as researchers, as data providers, to build that trust and understanding, to show people that actually their individual health data improves the health of populations. So last year there was this big campaign asking people to opt out of sharing their health data, so that, for example, the data that I use is entered by a GP in the consultation, and then it's anonymized. I get just the coded data, including people's ethnic group. So people were being asked to say, tell your GP you don't want to share your data for research purposes, which of course anyone is allowed to do. But as a research group at my university, we tried to release some publications on social media about how important and valuable people's health data is to us and how we strive to keep it safe. And that as soon as the data we have stops being representative of the population, we can no longer answer questions related to people's health, because we don't have the correct tools to make kind of unbiased findings about the questions that we're asking. And also related to Orkan's earlier point, I think the COVID pandemic has gone a long way towards raising people's understanding about ethnic inequalities in health, how their data can be helpful. So I think there has been a bit of a shift in public opinion, which hopefully will help bolster the quality and completeness of these data going forward. As an epidemiologist using routine sources of data, one of the major issues we have is lack of linked data across different settings. So in the electronic health records, we have information on people's ethnicity and an area level marker of deprivation, but we don't have information on people's education, their employment, and their housing conditions. So in order to build a complete picture of people's experiences and drivers of health inequalities, we really need to push for better linkage between health and administrative data sets. And I think the COVID-19 pandemic has been instrumental in showing that actually data can be joined up. If there's an emergency, people can really come together to create great resources. And so it seems that a lot of the delay in this kind of progress is mainly kind of due to like political factors rather than anything technological about how data sets can be joined up. And I think the last thing I wanted to say about the data is that, these coded electronic health records can't tell us everything, and really we rely a lot on qualitative work and community engagement to fill in the gaps and the context about how to interpret the findings that we see, laid out in our quantitative and statistical analyses. So the multidisciplinary approach to gathering high quality, meaningful data on disparities, ethnicity, and diversity is really the way forward.
Yeah, thank you very much, Rohini. I think this is a very accurate assessment of what we are facing as researchers, and also of our self-understanding and our purposes and approaches that we should be considering when we are dealing with data. Especially, I also like the linkage and the interdisciplinarity that you again highlighted, so that it's really I think, at the core of this whole challenge, that we should work together from different disciplines, but also from different disciplines inside maybe the health science sector, to come together and provide our expertise and exchange our ideas here. I think what builds us quite nicely a bridge back to Orkan's work also is this mutual connection that you've mentioned. So between the willingness to provide your health data maybe for research, and on the other hand, then seeing them put into practice in an understandable way, so seeing the outcomes and them being presented also in a manner that the majority of the population is also able to draw something from. So relating back to the concept of health literacy. And with that, I would also like to go back to Orkan again for addressing the topic of health literacy in diverse groups. So you've talked about health literacy in the pandemic, and how would you assess the health literacy of diverse groups in general, but also especially in the pandemic, and also especially in what we see in the fight against misinformation and also maybe vaccine hesitancy?
Right. So first of all, since my focus with health literacy research is mainly on children and adolescents, I consider them a part of the diverse group, because what I do or what we do in our projects is not the same that one can do or would do when researching health literacy with adults, especially not with adult patients. So therefore, children and adolescents, just to answer the question, what are the diverse or the vulnerable or the high-risk groups? I consider children and adolescents as high-risk or vulnerable groups that need to be addressed. And well, besides that, of course, we have families, especially young families, or becoming families, young parents in the first couple of years in early childhood. Then we have the elderly. They are a high-risk group. This is something that our data shows, that elderly have more problems with health literacy, or since we measure health literacy as a self-report concept, so we ask people how easy or difficult is some task in relation to information in context of promotion, prevention, or healthcare, and they report back to us based on their experience. It could also be that the elderly have just much more experience and can state it much more validly, and therefore have lower levels of health literacy, because they say, oh, these things are all difficult because I know from experience. It could be that this has nothing to do with their own competence. We have chronic patients, people with chronic diseases. They are part of the high-risk group, and of course, we just heard the topic of health inequalities, equity, health equity, and how significant it is in context of diversity. We have the people with low education, with low income, and overall from a lower socioeconomic status beyond factors that are related to education and income, that mostly turn up to be, except in our study with students, the people with lower levels of health literacy. So we can, across all the studies, and even across all the studies based on different understandings of health literacy, we see the low health literacy follows the social gradient. The lower the social position in society, the higher the likelihood of having lower levels of health literacy. So in order to address these different groups, of course, we cannot use a universal approach, a one size that fits all. But we need kind of a target group specific approaches. As I said, when I'm doing the research with children, and what we do is we analyze children and adolescents and their environments. What are their needs? What do we need to do when it comes to health literacy, when we want to address it there? We have developed a model called the 6D model, The D stands for different dimensions in relation to child health that begin with the word D, for example, demographics, differential disease epidemiology, development, digital worlds, democracy, etc., etc. All things that are unique to children and how they are unique to children. We use it to analyze these factors and then, for example, turn up when we look at development, then we end up having different health literacy approaches depending on the psychological developmental stage of the child. So you see, this is a way how to provide target group specific approaches. And of course, this is something that needs to be done for all the other vulnerable groups as well. When you address health literacy in elderly, you have to understand what are their biggest problems, what are their needs. Sometimes it could be that you just have to increase their health literacy, but sometimes it could also be that they have someone in their close social network who is helping them. For example, when receiving healthcare services, when going to the doctor, in context of health communication, someone who gives them the information and the knowledge that is relevant, someone who takes care of everything related to that elderly's health. And so another approach could then be to address that person. You see, it's a different intervention approach, but you have to consider that when addressing health literacy, it's not all the time only about a behavioral approach, since we are talking about diversity and health inequalities, but it is rather a structural approach. If we want to help someone, we have to improve the environment one is embedded in. The social determinants of health, they need to be improved. And the same is true for people with lower socioeconomic status who turn up to have more often lower levels of health literacy than people who are higher educated or who have higher income. And there are different concepts. I mentioned earlier, we cannot use just universal approaches, one size fits all approach. But in the health inequalities research, there are shaped approaches. For example, the proportionate universalism. It is based on universal approach, but it is designed to meet the needs of vulnerable groups proportionate to their degree of disadvantage. So you see, we have an intervention that should do the trick for all, but when we implement it or when it is accessed by vulnerable groups, they have a higher benefit, because we know from prevention research from Germany, but also from abroad, that there is the so-called prevention dilemma. Often interventions fail to reach the group that need the interventions most, and the proportionate universalism could be a mechanism to prevent it. And when I look, for example, just to put it in more practical ways, depicting it more practically, when I look at the health communication strategy of the government, the media, the broadcasting agencies that is going on for 2 years, I would say this is some kind of proportionate universalism, because the intervention, the information campaign is directed towards the whole population, but it is designed in a way and so easy that also the people who usually have difficulties understanding this kind of information or using that kind of information are able to understand it. So everybody benefits from it, but in particular, those who have the most problems. It also could have been different. The whole strategy could have been based on using very complex medical terms, giving complex recommendations, or even recommendations that nobody can apply. But in fact, here we don't have it like that. It is rather very easy to summarize it. So we need to understand who is our target group. Then we need to understand what are their main characteristics, what are their needs, what are their demands, what are their wishes and interests, and how can we address them when we address health literacy. And this will differ across all target groups. And then we only have addressed personal health literacy. At the beginning, when you introduced me, you said that on the one hand, it's personal health literacy, but on the other hand, it is systemic. And this is totally true, because in the discourse and the discussion surrounding health literacy, we not only have the concept of personal health literacy, but we have the concept of system level and organizational health literacy. And it has many dimensions. And first, before addressing the personal health literacy, we have to make sure that the systems people interact with, could be the healthcare sector, but could also be the media, or even everything related to their job, or what they do in their leisure time, that these systems are improved, are designed in a way to meet the target group's needs. So we have to improve the health literacy, or the capacities, or the infrastructures of professionals in education and social work, in health. We need to even address the physical infrastructure of buildings, because not all buildings are barrier-free or self-explaining. So there are a lot of complexities, especially in the healthcare sector, or the health insurers, or a very good example also are the online registration platforms for the vaccination. And they are complex, they are very complex, and people who struggle with their skills and competencies start registering, but the whole process is so complicated. They have to do so many things that they leave it to that. And then they miss, for example, their chance of getting a shot, or they search somewhere else on the internet and find, for example, their physician or vaccination center where they just can go to without registration and just receive the shot. So you see, there are a lot of infrastructures that need to be addressed. And this goes hand in hand with the personal health literacy capacities that we have to address. Yeah, so I think that's that. I hope this answers your question.
Yeah, definitely. Thank you. I think it also again underlines what we were discussing before, so that we really need to be aware of these different levels, personal, systemic, and of the different factors that influence the outcomes. So both in the vulnerability of populations to the pandemic, but also in general when we try to counteract this in gathering through gathering data, or also through public health measures. We are unfortunately fast running out of time, so I would already pose my final question to both of our speakers, which goes a bit into the future. So if you look at this interdisciplinary field of cooperation that we have been talking about also in today's webinar, of on working on the topic of health and diversity, which lessons do you think could be learned from this interdisciplinary cooperation? Where is it most important to have such a cooperation? And also, which lessons can we draw in general on the relationship between diversity and health in regards to the COVID-19 pandemic? And what do you think are the most pressing issue areas, or the most important areas for research that have to be tackled in this field in the next time frame? Maybe if you could go first, Rohini.
Thank you. So I think the discussion today has highlighted some of the really key issues. And I think the main thing is that, whatever we talk about in relation to the COVID-19 pandemic is going to be true for all health outcomes. COVID-19 is nothing new, but it's highlighted all of these disparities across different axes, which we really need to focus on. So I think from my perspective, in addition to sort of improving the joined up working between qualitative and quantitative approaches, is really drawing on the expertise from communities that we work with. So talking to community leaders, but also talking to people about their lived experiences. And I think that is one of the key things that maybe we as epidemiologists and researchers have not done as much. And I think, so much of what we see in health disparities is driven by structural factors: housing, occupation, workplace rights, and income inequality. And so really it's about, driving governments and policymakers to make these high-level changes, because any kind of policy which improves the health for all will have an outsized benefit for minority and diverse groups who are already poorly impacted. And so I think there've already been great strides in this, particularly with workplace protections and, thinking about vaccination and health literacy. So really, yeah, it's about sort of building on what we know. And I think we already know a lot. I don't think we need more research into what drives COVID, what drives inequalities. These stories have been told over and over again. And it's really now about pushing for that change in how our societies and our countries are run.
Yeah, thank you. I think that's a very important point, so that we also have to go from our impact as researchers, or to try to have an impact also as researchers, going from data collection to really the concrete implementation also of what needs to be addressed. Yeah, Orkan, what do you think about the future of the field, so to say?
Yeah, I'm on the same page like Rohini. She's totally right. We often say at the end of our papers and our studies, we need more research, but in fact, the evidence that we have, especially on how to reduce health inequalities and increase health equity, is there. What we need now is action. And when we look at social science and life science and how they could collaborate, the action must come first from the top-down level. It must be supported, enabled, funded through legislation. So there must be some there must be resources available to transfer our research findings into practical action to reduce inequalities and increase equity. That's the thing that we need on the action level. And so we need a collaboration between policy and practice, but also, of course, with us, with researchers. And when I say we don't need more research, I mean we don't need more research to generate information about the problem. We know the problem. What we would need, if there would be action that is being implemented, we would then research to evaluate that action and see what kind of effect that action has. And there will always be room and space and opportunity and need for research, but we have to shift the focus to that action. But I cannot, like Rohini, I cannot say, yeah, there is already that action. There is already a lot happening. A bit is happening, a lot is known, a bit is happening, but there is much more room for improvement. And once there is this kind of action available, then I see many, many opportunities for us researchers to accompany those who implement that action and see whether that what they are doing, of course, with our help, is effective, has a scientific basis that one can measure and account for.
Yeah, this is a very important concluding note for our webinar, I think. So indeed, we can, as researchers, follow our interests and gather data and put the issues on the table, but then we also need the top-down support, as you were saying, also to be able to actually make then a difference in the implementation and through that also to combat these inequalities that we have heard about today and that lie, I think, at the root of many of the issues that we were discussing here. Not just in regards to diversity, but of course, especially in regard to diverse populations who tend to be more affected by these issues in general, and not just during the COVID-19 pandemic, but in terms of health inequalities and social determinants of health in general. So we have a powerful call for action here from our speakers today. And we hope that maybe some of the policymakers will hear this call and be receptive to research findings and also to collaborating with researchers and research institutions in order to improve the situation for the whole population, including diverse populations. So as a final word, I would just like to give great thanks to our speakers today, so to Rohini, Mathur and Orkan, who have provided us with some very interesting insights, and I think have underlined how important it is to look together also from an interdisciplinary point of view when we are looking at the topic of health and diversity. And of course, I would like to also thank our audience for participating today. And I think my colleague Johanna has already posted some interesting links for you in the chat. So to our webinar series and also to the next events that will be held over the next few months. And we also have a research blog on mobile people and diverse societies, which I also warmly recommend as reading in the meantime until the next webinar. So thank you very much to our speakers, and I hope to be able to welcome some of our audience today again for the next webinar. Thank you.